here, and she's from University of Texas Health Science Center, so please give her a warm welcome. Thank you.
Hi. As you said, my name is Dr. Melissa Martinez. I'm the medical director of the Transitional Care Clinic over at University Plaza, and I'm going to be talking to you about transitional mental health care. As you'll see, we actually haven't seen that many older patients, but I actually think it's based on what I've been saying, it's an underutilized resource in this community and potentially others. So I won't be moving around that much. I hear this is the best place or way to carry the sound. So we'll just go forward from here. The good news is that my presentation is short. The unfortunate news is that if you have it in front of you, it's changed around a little bit, so I would pay attention to the projector in front of you instead of any paper presentations you have. So as you all know, the baby boomers are getting older, and by 2030 they will be at least 20% of the population and are the fastest growing portion of the population today. Therefore, the American government has actually declared mental health a priority in this population. Common concerns in this population include depression. There's a 10% lifetime prevalence of depression in this population. There's also a 7.6% lifetime prevalence of anxiety in this population. Since the women outnumber the men, that means, and depression and anxiety are twice as common in women compared to men, that means depression and anxiety are going to be significant concerns in this age group. In addition, over 50% of these people tend to go to their primary health care practitioners for treatment of these conditions. In fact, less than 3% see specialized practitioners for treatment of these conditions. So what are the implications of that? There's a lot of downstream effects of mental health problems in these individuals. Unfortunately, depression is an independent predictor of poor long-term functional outcome post-stroke, poor outcome 6 months post-CABG, cardiac hospitalization, continued pain, failure to return to previous activity, and increased cardiovascular mortality 2 years after coronary artery bypass graft. In addition, being older is one of the significant risk factors for suicides. Chronic medical illness, which is one of the things that happens as you get older, you develop chronic medical problems. Mental illness, being single, divorced, or widowed, which is something that develops sometimes as you get older, and poor social support, which can happen as people retire, leave their places of employment, which do provide sources of social support for these people. All these things are risk factors for suicide. And when you look at the suicide rates, for males who are over 65, the suicide rate is 14.89 per 100,000. I'm sorry, the suicide rate is 29 per 100,000, which is significantly higher than it is for all ages. So we have a challenging situation ahead. We have a limited mental health care prescriber. We have an increasing population needing mental health care, and we have long wait times for appointments for these people. In fact, I had one of the people in my clinic call around to see how long it would be to get in to see a geriatric psychiatrist in the community. And this was a geriatric, these are even for geriatric psychiatrists just starting out, who just graduated from residency, or from fellowship. The wait time was 6 months, and this was within, 6 weeks, and this was within a month of this person just graduating from fellowship. So, unfortunately, these people get backed up relatively soon. So how do you solve this problem? How do you get these people the help that they need? Well, you create a clinic that provides care for patients while they are waiting to establish care with long-term prescribers, and then also that provides care while they are waiting just to get back into care with their long-term prescribers if they have fallen off of their long-term prescriber's radar. It also can train more behavioral health care practitioners. A clinic like that was established here in San Antonio called the Transitional Care Clinic, based on the generosity of Methodist Healthcare Ministries and UTHSCSA. The purpose of the Transitional Care Clinic is to provide care during that gap time. The Transitional Care Clinic is an interdisciplinary outpatient behavioral health clinic that provides care for patients after they have been discharged from the hospital or the emergency room while they are waiting for long-term care. So transitional care, actually for people who provide care for patients, for geriatric patients, you're actually probably pretty familiar with the concept of transitional care. It's a set of actions that ensures coordination and continuity of care, transition between levels of care, and it's based on comprehensive plans of care, availability of well-trained practitioners, and current information of patients' goals and status. First, the person is seen at the hospital. So an identified point of entry was established. For the Transitional Care Clinic here at UTHSCSA, the point of entry was the hospital, the ER, or the inpatient unit. We also identified who we could best help: adults, anyone over 18 years old, who had transportation to and from the clinic. They needed to be able to participate safely in routine outpatient care, and they had to have a primary psychotic, anxiety, or mood disorder. We also accept patients who struggle with dementia, but we actually just haven't been referred that many patients who do struggle with dementia, and you'll see that in the numbers. So good fit examples are patients who struggle with schizophrenia, bipolar disorder, major depressive disorder, anxiety, or dementia mild to moderate. So what happens is when the patient is identified at the hospital, the referring provider gets onto the computer anytime, night or day, and logs into this electronic referral process. There's a username and a password. They select an appointment date that works best for the patient. It's not provider determined, it's actually patient determined. So the patient is in the hospital, the person that sees them says, when do you want to go see your outpatient provider? Do you want to go Monday? Do you want to go Tuesday? Do you want to go Wednesday? When do you want to go see your outpatient provider? The only thing that is determined by our clinic is that they can only come at 8:45 in the morning, but they can come any day of the week. They also attach collateral from the inpatient visit or from the ER visit. They need to attach the collateral, the write-up from the note of that visit. This is the inpatient, the log-on page. The most important, I know it's a busy slide, the most important points that I wanted to make sure that you were aware of. I'm trying to find, where is the, oops, let's go back. That's forward. It's just using the finger. Oh, there we go. Okay. The most important things I wanted you to see are that it says here, there's home number, work number, cell number, and it also identifies who will be taking you to the Transitional Care Clinic. We identify, we want someone to take them to the Transitional Care Clinic. We also want at least 3 numbers to call them. This is because before they even come to the clinic, well, let me back up. While they are even at the hospital, we send somebody out to the hospital. An outreach coordinator goes out to the hospital and meets them at the hospital and says, hi, my name is Lisa. I'm from the Transitional Care Clinic, and I just want to welcome you to the Transitional Care Clinic, and we look forward to working with you when you arrive. There's a warm handoff. 2, we have these numbers. Whenever this arrow shows up again, we have these numbers. We have somebody from the clinic call them and say, hi, my name is Mary. We're looking forward to when you show up for your appointment. Just a reminder, your appointment is tomorrow at 8:45. 3, we also have someone identified who will bring them to the clinic. We do whatever we can to make sure that the patient will show up and doesn't fall through the cracks. Despite that, only 40% of the patients show. When they show up, there's a group process. So the patients come in, they're in a group setting, they tell basic information. How many days worth of medications do they have? Are they in danger of hurting themselves or other people? And are they having troublesome side effects from their medication? Based on basic information, the patient's assigned an appointment with a prescriber within the next 2 weeks, same day to within the next 2 weeks. Then also, if it's somebody says, you know what, I'm getting kicked out of my apartment, they meet with a social worker who will help them with their immediate needs. I'm getting kicked out of my apartment and I have no food. Okay, you're also going to meet with a social worker today who will help you with that. That is how their needs are immediately assessed, and that is how we can assign appointments for people as quickly as possible and provide them with next day service based on when the patient wants to come in. In addition, there's a special service we provide at the clinic called cognitive adaptation training. This is a service where someone will go into the house if the patient gives them permission. Then will help the patient set up their environment in a way that allows them to better organize their environment so that they can remember to take their medications and remember to keep their appointments. Many of the patients, when they're in the middle of a mood episode or a psychotic episode, their executive functioning is not as, optimal as it is when they're functioning in a euthymic state. Therefore, they need help with executive functioning. So we'll set up cues in their environment. We'll set up signs. Remember to take your medication in the morning. We'll set up pill boxes. Here's your medications that you take Monday in the morning, Monday in the evening. We'll set up calendars. On Monday, go to your doctor's appointment. On Wednesday, go to your therapy appointment. We'll help clean up around their bathroom so that it's neat to help them see their pill box and it's not lost in the middle of everything around their bathroom counter. So that's what the people who do cognitive adaptation training do. The services provided include medication management, psychotherapy, individual, again, cognitive adaptation training, and case management. From the patient's experience, they come in for intake, then they are scheduled for a prescriber assessment, then they do medication management follow-up and case management. Psychotherapy is also assigned if indicated, and then eventually they are transitioned out to a long-term prescriber. As of May 2014, the clinic was opened in April of 2012. Over 1,400 patients were seen. Approximately 3% of those were 61, over 61, 0.3% were over 71, and 0.2% were over 81. When I broke that down over, according to diagnosis, approximately half of those patients were depressed, about a third of those patients were anxious, 10% had bipolar disorder, only 7% had cognitive disorder NOS, and only 7% had schizophrenia or some form of psychosis. When I added in by depression with psychotic features, that jumped up to 14%. So as you can see, it's actually a pretty underutilized resource for the aging. In addition to providing care for people, it is the TCC is an interdisciplinary training clinic for psychiatry residents, medical students, advanced practice nursing students, physician assistants, and psychology interns. as well as social work interns and LPCs to help them learn how to do case management and counseling. The whole purpose is to increase the number of people who are able to provide care for the population who have mental health care needs. So in conclusion, the treatment of mental illness in the elderly is imperative for multiple reasons. It has potential suicide implications and possible impacts on medical comorbidities. Based on the numbers I found after running them in our clinic, the TCC is perhaps an underutilized resource for elderly adults, and I'm not quite sure why. For some reason, I'm not sure where they're going, but they're not coming to us. Perhaps it's because over 50%, like I saw, are just being seen by their primary care physicians, and they're keeping them there. So, that's about it. Told you it would be very short.
What span of time do you keep the patients in your program?
The program originally was written to take care of patients for 90 days. However, we found that we keep them for as long, probably shouldn't publicize this, we keep them for as long as we need to. You know, some patients were able to transition out in a month, 2 months. There are some patients we need to keep for 6 months. Our rule of thumb is we take care of a patient for as long as we need to keep them stable. For elderly patients, they have Medicare, right? And so, for example, I was just looking up, as I was gathering the data for this presentation, the elderly patients, you know, we're going to keep them until I can find someone who will take care of them who has Medicare, right? So, I took care, you know, I didn't run the numbers for how long we took care of these patients until we transitioned them out. But they're actually going to be easier to transition out because we will be able to find providers for them. We have many patients that don't have insurance that I take care of as long as I need to keep them stable until I can find someone for them. Yes?
What do you do about the 60% of patients who are no-shows?
The 60% of patients who are no-shows. There's not much I can do, unfortunately. We're trying to figure out why they are no-shows. They're referred from the hospital, and we're trying to study what are the difference in the factors, why they are no-shows. We're trying to look at the demographics and what happens. People are still able to refer them to the clinic again, and hopefully next time they show up. And when they show up, we ask them, what kept you from coming the last time? So we're trying to implement measures to study what kept them from showing up the first time around to the clinic, because that's the whole purpose of the clinic, to understand what is interfering with people's ability to participate in care, because we want to increase people's ability to participate in care. But those patients, we don't know. They weren't our patients, but to begin with. And so we just stay open and welcome as many people as we can.
You don't get the feeling that those are the older patients who maybe don't have transportation?
That's a great point. We need to, what would be helpful, we need to run the numbers on the patients that are the no-shows, and run the numbers on what their age group is and what their other demographics are. So those numbers probably do need to be run. But we don't have, other than age, we don't have a significant amount. Well, we have to go back and see what information we have on those people to see what we can run on those people. Yes?
With the home visits that y'all do, is that just a one-time thing? So then once you get there, and you see that there's issues, who pays for that? Is that Medicare pay for that, or Medicaid? What insurances pay for that?
At the current time, the clinic is grant funded.
Okay.
And so the challenge in the future is to figure out how that can be funded. care coordination, from my understanding, care coordination, social work visits, those kinds of visits, there's a way to transition so that visits, you know, can be funded, but it's going to require some study. CHCS also uses CAT visits as well. So it's a matter of figuring out what mechanism can be used so that those kinds of visits can be funded.
And what's usually the length of time that you're in the home when you go there? Like, is it 20 minutes, 30 minutes?
That depends on the person and the need. Yes.
So if I understand correctly, the way that you would get a referral, someone would get into your service, into the program would be because the hospital refers them?
The hospital refers them. The grant was set up with the hospitals as an identified point of entry.
So is there any other way?
Not at the current time.
That's why it's underutilized.
That's why I was going to say, that's why it's under, utilized like one thing, because a lot of your elderly, they go in for another chronic illness and be diagnosed for that and not for the mental part of it. And I would just suggest if there's other entities in the community that can refer into the services, you would definitely have a lot more elderly that would be utilizing your program.
Okay. So, yes, so thank you. We'll definitely bring that up. What types of entities would you?
Alamo area, aging and disability, APS,
Your healthcare industry,
all
anything in your
anything
healthcare
in
industry.
healthcare. Because, I mean, not everyone goes to, you know, UT, Health Science Center. So you've got all of these other hospitals that would utilize home health agencies, provider services. I mean, you've got a whole realm that is not being able to utilize the services because it's strictly for that particular hospital, which is a great service to have, but that's why it's not being utilized.
Well, it's actually open to multiple hospitals, actually.
Oh, okay.
And then the other thing is, because most of the time when an elderly person gets to that point of going to the hospital, unfortunately their mental illness, whether it be depression or any other kind of mental illness, that's not looked at first. It's always their chronic illness of diabetes, high blood pressure, anything else. There are many times that I run across where I have clients that have yes, chronic illness of blood pressure, diabetes, but yet they have depression, anxiety, and they're treated more for the chronic illness and not for the mental illness.
And what about consulting, the consult service?
When you're not a family member and you're not allowed to go and talk to the social workers, it's kind of hard to relay that information.
And most doctors want the family to relay that to them, not
A caregiver.
a caregiver agency.
Got it. Yeah, no, so what I'm hearing is that it sounds like there's opportunities for additional grants,
Yes.
which
Yes.
sounds great. You know, that's very exciting, right? Go ahead.
What other hospitals do you accept referrals from? I work at Methodist Specialty, so.
Oh, yes. So,
I make
yeah.
referrals.
Yeah,
What
we
other hospitals?
We accept referrals at the current time from Methodist Specialty, from UH, and from SAMC. And we're in discussion with another hospital at the current time. And so slowly but surely, as our systems have been solidifying and becoming more efficient, we are opening to more hospitals. So it's very exciting, actually. So we're very excited about that. I'm still thinking about that person's questions about analyzing the numbers for the people that don't show. And are we losing some of the elderly in the people that don't show, which I think would be unfortunate. Because maybe they don't have transportation to get there. Go ahead.
Do you have, is it just Bear County residents? I may have missed that part earlier. Or do you extend out to St. Floresville, Pleasanton, and those areas?
So we accept referrals from Methodist, Specialty Transplant, UH, and SAMC at the current time. If they have taken people who are outside of Bear County, then we accept them. We don't exclude them. And so we don't have an exclusionary criteria related to county. Some of our challenges have been, though, once we get them, how do we transition them on? Because we can't get them CareLink, and CHCS won't take them. So we're stuck with transitioning them on to Blue Bonnet and these other areas, and so that has been a bit challenging. The answer to your question is yes, we do, if we get them via these other mechanisms.
Do you do a follow-up question or telephone call to those who don't show up?
I'm trying to think, I think that they do, but I'm not sure. I think they were doing them. I'm not in charge of that segment. I think that they were doing it, but I'm not sure if they are anymore. I could, if you want me to get your email, I can get back to you on that question. There is somebody else who's in charge of that portion of operations. So I know for sure they are calling everybody before they're showing, and I'm not sure if they're following up on that. I know for sure they're calling them and saying, hey, are you going to show? Oh, you can't show, let's reschedule you. So, any other questions?
All right, well, thank you so much. Thank you so much for the presentation. We do have a little bit of time before our next speaker, so what we're going to do is take a quick 10-minute break. We're going to try to locate the next speaker to see if he can come early. And right now it is a couple minutes before 10:30, so at 10:40 we're going to try and attempt to start again. And again, right now is a good time to take a bathroom break, grab some coffee, and again we'll start around 10:40 or so. Thank you.